Welcome, everyone. I am Dr. Kelly Roof, a clinical educator here at Precision Analytical, makers of the Dutch test. Thank you all for joining us for this webinar with our very own clinical educator, Dr. Christina O'Brien. In this webinar, we will explore the intersection of metabolomics, hormone dynamics, and genetics in understanding cognitive health. Our focus will be on critical organic acids like HVA, VMA, Kynurenate, and Quinolate, which are key indicators of neurotransmitter activity in the brain. We will discuss how these metabolites interact with crucial hormones like estrogen and cortisol, how their modulation can influence cognitive function and susceptibility to mental health conditions. And this talk will also extend into the genetic predispositions that affect these metabolic pathways, providing a holistic view of individual biochemical variations and their impact on brain health. If you're ready to start using Dutch testing in your practice, sign up as a registered provider today. It's easy. Just click the link we posted in the chat and complete our provider application form. A member of our onboarding team will then walk you through the steps to set up an account so you can begin taking advantage of all the education and resources that Dutch has to offer. And there are a lot. Plus, registered providers gain access to the Mastering Functional Hormone Testing course, the Dutch Interpretive Guide, and one-on-one consultations with Dutch clinical experts like myself and Dr. O'Brien. This dedicated support and education is designed to help you become the hormone expert. Now, let me introduce today's speaker. Dr. Christina O'Brien is a highly skilled and compassionate healthcare professional with years of experience in helping her patients achieve optimal health and wellness. She earned her Doctor of Chiropractic degree from Sherman College in Spartanburg, South Carolina, and her Bachelor of Science in Nutrition and Dietetics from the University of Massachusetts at Amherst, with a dietetic internship at Winthrop University in Rock Hill, South Carolina. As a clinical educator with Precision Analytical, Dr. O'Brien is a part of a team of doctors who are highly regarded in the functional medicine testing world. Her expertise and experience are highly valued by Precision Analytical, and she is frequently asked for by name to consult on tough hormone cases. And now, without further ado, let's get started with today's webinar.
Hello, everyone, and thank you for joining today's webinar. My name is Dr. Christina O'Brien, and I specialize in functional medicine with a focus on women's hormones and nutrition. Today, we delve into the fascinating world of metabolomics and its application in cognitive health through the lens of organic acids. This session is designed for healthcare professionals who are keen to enhance their understanding of neurochemical dynamics in clinical practice. Next slide. So remember, the information in this presentation is provided for informational and educational purposes only and is not medical or treatment advice. Also, any information and statements regarding dietary or herbal supplements have not been evaluated by the FDA, and the use of any information provided in this presentation is solely at your own risk. Next slide. So, some objectives for today's presentation are understanding the role of organic acids, the impact of genetics on metabolite pathways, exploring neurotransmitter hormone interactions, practical applications of the Dutch test, and then equipping practitioners with hopefully some helpful tools and tips that you did not know of before you attended today's webinar. Next slide. Okay, so the main excitatory or stimulating neurotransmitters are acetylcholine, adrenaline, dopamine, glutamate, histamine, noradrenaline, and PEA. And the key inhibitory or calming neurotransmitters are GABA, serotonin, and melatonin, and their life cycle involves synthesis, signaling, transport, and metabolism within and outside the cell. The importance of neurotransmitters in cognitive health is that by analyzing organic acids, clinicians can hopefully gain insights into a patient's neurochemical balance and hormonal health. For example, elevated quinolinic acid, which we see on page 6 of the Dutch test, can indicate neuroinflammation or dysfunction in neurotransmitter synthesis. And we're going to go into a whole lot more detail as we move through of quinolinate and HVA and VMA, dopamine, epinephrine, norepinephrine, and other markers. But we want really to look at things from a holistic perspective and start to find clues not only within page 6, the neurotransmitters, but clues throughout the Dutch test with adrenal hormones and sex hormones and tie everything together ultimately. Next slide. So, the science of metabolomics is the study of small molecule metabolites within an organism, which are crucial to biochemical processes. And by studying these small molecules, metabolomics provides insights into the systemic response to biological stress, disease states, and drug efficacy. And it allows for a really deep understanding of the biochemical responses of the body to various physiological and pathological conditions, hopefully to be able to prevent diseases from happening rather than mitigate and manage the diseases once they're present. The organic acid test measures the level of organic compounds in the urine that are produced in the body as part of vital biochemical pathways. This is next slide. Organic acids are products of intermediary metabolism, often involved in essential pathways like the Krebs cycle, amino acid metabolism, and fatty acid oxidation. And organic acids, which are easily detectable in urine, serve as valuable diagnostic markers. When they're high or low, they can indicate either genetic mutations or specific enzyme deficiencies, nutrient imbalances, or inherited metabolic disorders. And you'll find that in conventional Western medicine, diagnostic medicine, typically they're looking for inherited metabolic disorders or more serious things like tumors when they're looking at organic acids. In functional medicine and preventative medicine, we want to see things like nutrient imbalances, enzyme deficiencies, potential genetic mutations, so we can more fully, holistically help the patient get better. So these are um, some of the organic acids that we're going to focus on. Next slide in more detail. We're going to see the impact of organic acids on the brain, and we're going to look at HVA, VMA, and kynurenate and quinolate. Those are going to be the primary neurotransmitters we're focusing on related to brain health, cognitive health, and brain function in general. And then we're going to touch on the other organic acids as well. So, HVA is a dopamine metabolite and it reflects dopamine degradation. Low HVA may suggest impaired dopamine metabolism linked with neurological disorders like Parkinson's disease. And sometimes when we think about page 6 on the Dutch test, we think about looking at HVA, VMA, quinolinate, the neuro related section of organic acids. And we always want to ask ourselves, is the patient really that person? Are they a low dopamine person, a flat affect, apathetic, addiction prone person? If they're not, sometimes we know that HVA levels, high or low, can be coming from other places, whether it's having eaten an avocado or banana, fava beans. We'll go through all of those things. But sometimes it's not really reflective of low dopamine. So we always want to look at, when we're looking at a Dutch test in general, and then specifically around the organic acids, we want to look at the trees, but then we always want to step back and look at the forest. And we want to look at that view and we want to look at it through the lens of the patient. And we want to put everything together from an inflammatory perspective, tying it in with HVA, VMA, quinolinate, and all of the other organic acids to really figure out how to create the most robust protocol for our patient. VMA is a metabolite of epinephrine and norepinephrine. It provides insights into the body's stress responses and is really important for diagnosing really serious things like a pheochromocytoma. Again, more in the Western medicine realm, but always when we see a really high VMA on the Dutch test, that's something we want to keep in mind and take into consideration. And the kynurenate and quinolinate are both in the same pathway. They are both tryptophan metabolites, tryptophan at the very top of the pathway and NAD plus at the very bottom. And straight through that pathway, which you'll see in future slides, we end up at quinolinate and NAD plus, and kynurenate is a branch off to the side of the tryptophan pathway, and kynurenate is known as more anti-inflammatory, while quinolinate is much more inflammatory. And we'll talk about some things that you can do to shift those pathways. Next slide. So, some practical applications of organic acid testing is that looking at organic acids, we're able to detect really subtle metabolic changes that are happening in the person and in the patient in the person. And the reason we're able to do that is because we use very sensitive testing methodology in order to be able to look at organic acids. We use the LC-MS-MS approach to detecting neurotransmitters or neurotransmitter metabolites in urine. And one of my favorite parts of working at the Dutch test is that Mark, our president and founder, is a chemist. And he is a chemist who happens to be extremely detail oriented. And we're not allowed to put anything on our test that is not completely validated, verified, statistically significant, and relevant to the patient. And that really, is part of the whole Dutch test and Dutch trust approach, because I know when I'm reviewing a Dutch test with providers, what I really am so proud of and what I love is that if there's a value that's out of range, whether it's estrogen or cortisol, I know for a fact that I can come up with 5 to 25 different reasons why metabolically your patient could be having a change in those markers, because I know the thing that's not going to enter into my head is that is potentially a testing error. And that's part of what makes Dutch so powerful, is that that doesn't even enter our brains. As a clinical education team, we know there are so many reasons why these things can be happening, and it's not related to testing error, which I love so much. So here is the urea acid cycle. We get to see all of the pathways that we learned in biochemistry. I remember creating a mnemonic of some sort to memorize all of these different steps, but this is just so you can see the steps in the pathway and know what we're looking at as we move through the presentation. Next slide. So, the metabolism of phenylalanine and tyrosine in the stress response is really important in understanding the biochemical basis of cognitive functions and neurological disorders due to their direct involvement in neurotransmitter pathways and brain metabolism. So, we know that catecholamines are released under stress. We know that medications are going to have a direct impact on those metabolites. So we always want to make sure we're looking at the medication that the patient is taking. And what we're going to do on a couple of slides is we're going to not only look at HVA and VMA, but we're going to compare those to one another, because the relative difference between those also makes a difference in how we interpret this test for the patient. One thing that's important to remember is metabolic byproducts of Clostridia, for example, can contribute to higher levels of both HVA and VMA, which is something I'm guilty of often not talking about when I'm reviewing a Dutch test with my practitioners. Important to consider those other little things, and hopefully we'll be able to, as we move through, find some things that you didn't realize or didn't remember about some of these neurotransmitters. Next slide. So this is page 6 of our Dutch test. And we look at the very top, MMA, which when it's elevated is a measure of a B12, usually adenosine or hydroxy B12 deficiency. There are some other things that means that we'll talk about in another slide. We see xanthurenate and kynurenate, which are typically B6 deficiencies, but not necessarily. When one is high or low compared to the other, it may mean something very different. Pyroglutamate, generally when it's above range, indicates a glutathione deficiency. Beta hydroxyisovalerate, when it's elevated, is a biotin, more than likely deficiency. And Indican, when that is at the high end of range, or when we're looking at that functionally through the lens of all of the other markers on the Dutch test, even when functionally in a female it starts to go above 50. If that female is having a lot of signs of inflammation, which we'll briefly address, that could be a whole presentation, I think, on its own. We're going to look into that. This is the Indican marker, is a window into gut health. And Indican tells us there's a potential bacterial dysbiosis or hypochlorhydria. And Indican's a great example of how really strict the lab is about having markers that are only really provable and statistically significant. We were begging, I feel like, for 3 years for a marker that could tell us in urine that there could be something happening in the gut. Hey, let's look at that more closely. And it took a long time of testing to find the marker that really worked. And that was perfect enough to put on our test. So in this case, we could see that a high end of range indican would mean potentially a bacterial dysbiosis or hypochlorhydria in the gut, which then, as you know, changes everything in hormone metabolism. We see HVA, VMA, and quinolate in those neuro-related markers section. Again, look at those through the lens of symptoms. We see melatonin, optimally 50 or between 50 and 85. And then 8-OHDG, which are levels of measurable DNA damage and oxidative stress in the urine, which we always want to tie together with other markers as well. Next slide. So this is supposed to be a talk just about neurotransmitters, but I cannot resist talking about one of my very favorite pages on the Dutch test. And I want to pull this in at the end to help you see the connection between the neurotransmitters and the hormones. We always want to look at estrogen and estrogen metabolites, and we have some genetic markers related to these, but we want to make sure, especially around neurotransmitters, that we're looking at estrogen. And what we see here is this is a lower level of estrogen compared to progesterone. We see, based on the slider bars, the patient is starting to move a little bit more toward that 4OH, but this patient is methylating really well at the bottom of the page. So we want to look at this again through the lens of everything else, and make sure that we're addressing everything that we need to, again, to create the most robust protocol for the patient. This is the cortisol awakening response. And this next slide, this is the cortisol awakening response. And this slide shows the difference between normal cortisol and elevated cortisol awakening response reflected on the Dutch test as a waking plus 30, and waking plus 60. This is a salivary component that is overlying the diurnal urinary curve that we see on the Dutch test. And then we see a low cortisol awakening response. We're going to touch on those things later because they relate really strongly to neurological health, cognitive health, brain function. We can see things start to surface in this cortisol awakening response. That's really exciting to me. I had a provider say, I don't know, a handful of months ago, "Oh, Brian, do you have a crystal ball? How are you able to see these things about my patient without even knowing my patient?" And it's so much fun to get to see those things in the cortisol awakening response, because those first three markers are actually not even really about adrenal health in general. They're a marker of hippocampal health, which is directly brain health. We want to see, how is that patient waking up? Are they responding to the day in a really flat way? Or are they responding to the day in a really overexcited way? And we'll talk about some differences as we move through related to brain health in general. So this is an example on the Dutch test of a Dutch plus with a low cortisol awakening response. Some things that can produce a low CAR are things like psychological burnout, sleep deprivation or sleep apnea, again, tying that into other things in the Dutch test, potentially eating too late at night, autoimmunity, blood sugar dysregulation, obesity, functional GI disorders, TBI, actual brain damage, chronic fatigue, PTSD, and childhood trauma can be linked to a low cortisol awakening response, systemic hypertension, and then some suppressive medications. There are other things as well. But the medications that we have the patient list on the bottom of page 1 of the requisition form address things that will either increase or decrease the cortisol awakening response. Next slide. This is a high cortisol awakening response. When we see this elevated CAR, this lower awakening, and then a much higher percentage, this patient has, instead of a 50 to 160% increase from waking to 30, they have a 320% increase. This is a patient um, that has an overactive HPA axis for some reason. They wake up super early naturally, potentially. They woke up panicking. They're having a lot of anxiety in the morning. They have depression, which is interesting, can be reflective in a high CAR. They have major depressive disorder, not seasonal affective disorder, but major depressive disorder. They have a really high anticipatory stress for the day, completely opposite of that low CAR. Something stressful that happened during the day can reflect with a high cortisol awakening response and blood sugar dysregulation, as well as actually at ovulation. There could be a higher CAR as well. Next slide. So we're going to dig into HVA and look more closely at dopamine. Next slide. This is in the diagram. What you're seeing here are my genetic test results. I wanted to bring in a little piece of genetics is one of my really huge passions. And when I'm talking to providers during consultations, we're often talking about genetic markers. You have their genetic markers for this, that, or the other because it's so powerful. We know that the functional labs, without having genetic data, the functional labs are going to show us the genetic presentation of the patient if we're not actively doing anything to change that pathway in one direction or another. So this is a test result from a lab called LifeCode GX, and these are my results. So I put them up here for you to see. It's the pathway where we can see how dopamine is made and then converted into HVA, but you could see the cofactors listed here and the genetic markers that are involved and ultimately responsible for making that conversion between dopamine and, let's say, HVA. And then some of the cofactors there that make a difference as well. The genetic part of this is much more complicated than that. I just wanted you to have this so you could see as we talk through um, genetics related to everything else that we're talking about. So, HVA is the breakdown product of dopamine, which is the feel good brain chemical. And HVA is the primary central, not peripheral dopamine metabolite. Dopamine cannot cross in or out of the blood brain barrier. So, first, phenylalanine is converted into tyrosine, which is catalyzed by phenylalanine hydroxylase enzyme, which uses BH4 tetrahydrobiopterin as a cofactor to make that transition. Then tyrosine hydroxylase catalyzes the conversion of tyrosine to L-DOPA, which with BH4 and vitamin D as a cofactor. And finally, L-DOPA is converted into dopamine via the DDC enzyme with vitamin B6 as a cofactor. The DRDs, which are dopamine receptors, are activated by dopamine, and the main metabolite of dopamine, HVA, is filtered out by the kidneys and then excreted in the urine. HVA is a major metabolic product of dopamine, serving as an indicator of dopamine metabolic activity, which is really important in the diagnosis and management of conditions that are dopamine driven, Parkinson's, for example. And schizophrenia is also a dopamine driven disease state. And HVA can provide insight into the functional status of the dopaminergic systems, helping in assessment and diagnosis of what's happening and monitoring potentially of treatments. Next slide. Um, in response to stress, the body increases the production of neurotransmitters like dopamine to enhance alertness, focus, and readiness to respond to the environment. And this higher activity results in an increased breakdown of dopamine, which then results in an elevated HVA in a urine organic acid test. The increase in HVA can be seen as a direct indicator of enhanced dopaminergic activity. Abnormal dopamine levels not only can be seen in Parkinson's and schizophrenia, but also ADHD. And what I found interesting in the research was that we used to think that dopamine was that patients who had schizophrenia made more dopamine, but we now have an understanding that they actually have a higher number of dopamine receptors, not necessarily dopamine production. And the body has feedback mechanisms that are going to speed up or slow down the production of dopamine. And chronic stress really plays a huge role in that, and how the brain uses dopamine and how it holds onto it, gets rid of it or holds onto it. Next slide. So these are some genetics that have a really big impact on cognitive and psychological health. Um, the cognitive effects, the changes in HVA due to long term stress, can impact cognitive functions like memory, attention, and executive functioning. And higher low dopamine levels can affect these cognitive domains differently, potentially leading to symptoms like difficulty concentrating, memory issues, or having a hard time making decisions. Classic for a low dopamine person. Some of the psychological effects we can see when there are genetic mutations like this, or an alteration in dopamine reflected in HVA, is mood and motivation. Um, HVA will reflect the levels of dopamine and help us to understand what drives the patient. Is their depression or anxiety stemming from a dopamine issue? Often, chronic stress is going to play a role. VDR, the genetic mutation for vitamin D, often plays a role because remember it's involved in that conversion process. And we always want to look at MAO and COMT because high estrogen and stress make MAO and the COMT enzyme activity, COMT function, which we could see at the bottom of page 3 on the Dutch test. Impaired function of either of those make estrogen and organic acids higher. So we're going to make that correlation between those two. Things like quercetin, oranges, green tea, and resveratrol can downregulate MAO in case we want to do that. And with somebody with a lot of aggression or a lot of anxiety, those things could actually make them worse, which is something to keep in mind. As a side note, too, regarding insulin and dopamine, research shows that insulin and dopamine are greatly tied, and high insulin can cause high levels of dopamine and high levels of HVA in some studies. So, again, tie those things together. Next slide. Some things that will increase or reduce HVA. We have a lot of these things written on our instructions. Eating foods like bananas, um, chocolate, tomatoes, tea, onions, which actually contain quercetin. Eating disorders may raise or lower HVA. Environmental factors like exposure to air pollution can change the levels of HVA, genetic conditions, neurological disorders, and tumors, which are the much more serious things related to elevated or lowered HVA. And in the research, we see that low levels of HVA are associated with ADHD, childhood trauma, interestingly enough, and MAOA deficiency, which is a rare genetic disorder. Again, much more serious, not a functional situation at all that primarily affects men. Next slide. Some of the diagnostic use of looking at HVA is that it can be part of a broader diagnostic approach to assessing the impact of chronic stress on a patient. It provides insight into the state of the dopaminergic system under stress, which can be used for targeting interventions. It's also an indicator of cognitive reserve. HVA levels in CSF, not urine, but CSF, have been investigated as potential indicators of cognitive reserve in conditions like Parkinson's and Alzheimer's. And higher HVA levels may correlate with better cognitive functioning in these neurodegenerative conditions. There's also a correlation with executive function. Research has shown that HVA levels can correlate with performance on tasks requiring executive functions such as problem solving, planning, and inhibition control. There's also an association with neuroplasticity, which when we talk about neuroplasticity, I work with actually a husband and wife team who use a lot of EMDR and ETT in helping patients overcome past trauma by helping them create new neuroplasticity, creating new pathways, and associating dopamine and by extension HVA is really important when we're attempting to change neuroplasticity in a patient and help them overcome trauma, which is really neuroplasticity, is the brain's ability to reorganize itself by making new connections and new pathways, which are really important for learning and memory and the way that we approach life in general. And there's also a link to circadian rhythm. So, dopamine levels and the subsequent production of HVA are influenced by circadian rhythms. And when those rhythms are disrupted, which are really common in people who are shift workers and people with sleep disorders, apnea is a great example, can lead to disturbance in dopamine metabolism, affecting their ability to focus, their cognitive functions, their attention span, their mood, and decision making. And then it can be predictive as well in psychiatric treatment. So we can monitor how well things are working by monitoring HVA levels, get a baseline, monitor after initial treatment, and then further treatments to see what's happening regarding how psychiatric treatments are developing and progressing in order to most optimize the patient's healing journey. Next slide. So the diagram is showing how, in the literature, our understanding of the biological impact of dopamine and its baseline and its peak really works together. And what we see is that this is the same peak of dopamine, but a consistency in reward lowers the amount of dopamine release because the initial baseline is higher. So essentially, what that means is when we're more consistent in our reward, we have to release less dopamine to achieve the same level of elevation. So, what can happen when our dopamine peak and baseline get further and further away is we become more and more reliant on that dopamine hit, like social media, other addictive behaviors, sugar, for example. The further away those things become. So it's important to, based on the literature that we see, really try to be consistent in the reward when it comes to the amount of dopamine released and raising our baseline to get closer to that peak so it's not quite as extreme. Exposure to certain environmental toxins, or the use of pharmacological modifiers, medications is a great example, can alter HVA. And again, really important for monitoring psychiatric disorders and how those are progressing. HVA itself has been studied for its antioxidant properties. And I think this really leaves some room and some potential future research for implications for understanding how we can use HVA and dopamine to help reduce levels of oxidative stress, tie that into pyroglutamate and glutathione and 8-OHDG, and really make a big comprehensive picture for the patient. It's also a potential marker in exercise physiology. I saw some preliminary studies that were indicating that exercise can increase HVA excretion in urine, reflecting increased central dopaminergic activity. And I thought that was pretty cool. That was something that I didn't know before. It suggested that HVA could potentially serve as a biomarker for physical activity levels or even athletic performance, which is a whole other level, which we're in so many ways trying to hack with an Oura Ring or a Fitbit or a Whoop strap or different things that we're using to look at our um, heart rate variability and how much stress we're experiencing in the day, and our bodies are responding to those things, and we can see a change in HVA reflecting that as well. And in only animal studies that I saw, alterations in HVA levels have been associated with behavioral changes. So, for example, what I saw was that changes in HVA concentrations in certain brain regions have been linked to aggression and social hierarchy in animals. So, looking at behavioral and psychological conditions potentially extending that to humans, HVA can have a considerable impact there. These are some dopamine boosting foods. Foods rich in healthy fats, lean proteins, omega 3s, chocolate, strawberries, blueberries, healthy nuts and seeds, foods rich in sulfur compounds, foods high in folate, apples, prunes, and bananas. Caffeine also increases the number of dopamine receptors that we have. And while HV is a metabolic product of dopamine, as levels can also be influenced by things that we eat, which is why we put that on our instructions. So, in case somebody eats one of the foods that's listed, the ones that we have listed are the foods that are going to increase HVA most. If they indicate it, we'll know that that's why the HVA level is potentially a little bit higher. And diets also that are deficient in tyrosine could lead to lower HVA levels, which could lead to lower dopamine related neurological functions. Next slide. We're going to look at VMA, which I think of as HVA's counterpart. Next slide. Noradrenaline is formed from dopamine using the dopamine beta hydroxylase enzyme. Again, my genetic markers for you to see here in that pathway. The DBH enzyme uses copper, oxygen, and vitamin C as cofactors, but copper overload can upregulate the pathway, depleting dopamine and creating too much noradrenaline. And the noradrenaline transporter, NET, which is encoded by the SLC6A2 gene, is a monoamine transporter and is responsible for the reuptake or removal of extracellular noradrenaline. And then noradrenaline is converted to the bottom of that pathway to adrenaline by the PNMT enzyme, which is stimulated by cortisol and with SAMe as a cofactor. VMA is the end product of the breakdown of those fight or flight hormones, norepinephrine and epinephrine, or noradrenaline and adrenaline on this diagram. And adrenaline and noradrenaline are produced in the adrenal gland and released into the bloodstream. Their main role is to prepare the body for physical stress. They make the heart rate increase, they increase blood pressure, they expand the lungs. They increase energy supply by mobilizing energy stores in the liver and in fat cells. And studies have found that VMA levels increase in response to severe stress and anxiety. Next slide. We see epinephrine and norepinephrine genetics here with a little bit more detail, remembering to look at VDR as well, which is related to vitamin D, which plays an important role in all of our neurotransmitters, especially dopamine. Next slide. So, some of the effects of adrenaline and noradrenaline are regulation of blood flow and cognition, epinephrine and norepinephrine, from which VMA is derived, play a role in regulating cerebral blood flow. During cognitive tasks, the brain requires more oxygen and nutrients, which are delivered through increased blood flow. The balance of these catecholamines and therefore VMA levels can influence cognitive performance by affecting how well the brain is supplied with necessary resources. VMA, as an end product of the metabolism of stress related hormones, can provide insights into an individual's physiological response to chronic stress. And chronic stress has been shown to impair cognitive flexibility, which is our ability to adapt to things that are happening that are stressful in our life. High VMA levels can indicate prolonged exposure to stressors, potentially leading to a decreased cognitive flexibility and poorer problem solving. Since VMA is a breakdown of both epinephrine and norepinephrine, it can serve as a broader indicator of neuroendocrine function, which is really important for maintaining cognitive and emotional stability. Disruptions in neuroendocrine balance reflected by abnormal VMA levels could contribute to various neuropsychiatric conditions like ADHD, anxiety, depression, and affecting cognitive functions like attention, memory, and emotional processing. There's also a potential role in pediatric developmental disorders related to ADHD and deficits in executive function, impulse control, and attention, all areas potentially influenced by catecholamine signaling. In clinical settings, watching HVA for levels of the efficacy of treatment that we're using to modify catecholamine levels can be very helpful when we're prescribing medications for ADHD. For example, we can use HVA to tell us, high or low, how effectively is the therapy working. And then certain lifestyle factors like caffeine and smoking are known to influence the VMA level directly, and both smoking and caffeine can stimulate the release of catecholamines, which will increase the production of VMA. Next slide. VMA is an indicator of the stress response, and beyond its role in diagnosing adrenal tumors, which is the biggest, and you'll see highest levels of VMA in those instances. VMA levels can also reflect directly the body's stress response. It's a major metabolite of epinephrine and norepinephrine, which we discussed, and it's really critical in the fight or flight, actually fight, flight, or freeze response. And studies have indicated that psychological or physical stress can lead to high levels of VMA, making it a biological marker for chronic stress exposure. And this is something that Dr. Jacqueline and I talked about in the summer podcast last summer. In cases of short-term stress, what you will typically see is an elevation of VMA. Those levels are going to go up really high or much higher when somebody's experiencing that fight or flight response. But what we see in cases of long term or chronic stress is the body will protect itself. And when we're looking at the Dutch test, it's amazing to me. The more Dutch tests I look at, and the longer that I analyze those tests, the less I actually do for the direct system, because of really, I think, appreciating the wisdom of the body. And what we start to see over time is that VMA levels are going to start to decrease as a protective mechanism. Long term stress, chronic stress, will start to downregulate that adrenaline production. The body gets to a point where it can no longer overproduce without risk of developing more serious and other conditions. So the body will adapt, and it's so amazing to see how the body adapts with these neurotransmitters, how it adapts with cortisol, right? We don't talk about it like adrenal fatigue anymore. We used to, when we were really first understanding what was happening with the adrenal glands, but it's really the way that the body is protecting itself. So we want to look at it always through that lens and figure out, where is that coming from? Is this chronic stress? And what can we do to help the patient most robustly? We want to protect the body from that wear and tear. Next slide. Foods that will increase epinephrine and norepinephrine: bananas, meat, legumes, chicken, cheese. Cheese is also something that will increase dopamine levels. It increases all of the precursors to dopamine. So those people who are, and I talk to patients in my office about, they've got a dairy sensitivity, and I'm telling them they need to stop eating dairy, and they start crying. I'm pretty sure they're making casomorphins or things that are, they're a low dopamine person, right? They need those precursors. So supplementing them with those things can make that transition sometimes a little bit easier in patients in general. And a fun little fact is that a daytime nap can also double your levels of norepinephrine. Next slide. Next, we're going to look at the HVA VMA ratio and briefly touch on some things that can change the ratio of those two things in general. Next slide. An elevated ratio, HVA and VMA, indicates a decreased conversion of dopamine to epinephrine, can be influenced by a Clostridia infection, by ADHD. It also checks for genetic disorders and neuroblastoma, which is a nerve cancer often found in the adrenal glands when these levels are extremely dysregulated. Next slide. So if HV is high and VMA is high, we want to look at the COMT or MAO. We want to look to see if the patient's taking tyrosine, DLPA, dopamine, or mucuna. We want to see if they're on SNRI. These are things that are going to increase both HVA and VMA. If they're using amphetamines or Drinking a lot of caffeine or pseudoephedrine hydrochloride will raise both HVA and VMA. Opioids can increase both. VMA could be normal in that case, but usually will increase both. We want to look at the adrenals. We want to address fight, flight, freeze, check inflammation, right? Really important in combining everything in the Dutch test when we're talking about inflammation, and then looking for much more serious things like a pheochromocytoma. We also want to make sure insulin levels are healthy and check the adrenals to see if cortisol levels are high. Address that if it's important, if we see that that's really the root of what's happening. Always finding the root. Next slide. If HVA is high and VMA is low or normal, it could be related to copper and vitamin C, since HVA converts to VMA with B6, copper, B2, magnesium, SAMe, and uses the MAO enzyme. HVA can be high if someone's taking quercetin supplements or eating foods that will increase HVA, bananas in particular. If they're using opioids, if their adrenals are showing lower cortisol production, VMA then is going to be usually low and not normal. Short term THC use raises dopamine, a higher HVA. If they have a DBH enzyme deficiency, which is something that's much more serious, and a neuroblastic tumor is going to increase HVA quite a bit, and VMA is going to be low or normal. Next slide. If HVA is low and VMA is high, we talked before about that being related to an acute stressor, something that's happening that's providing way too much stress for the patient's body. When VMA is high, people can have feelings of anxiety, insomnia, hypervigilance, sweating, heart racing. We always want to look to insulin levels to make sure those are healthy, and look to the adrenals to make sure that the cortisol values are normal. Treat those things as you see fit. And remember that stimulants like amphetamines, caffeine can increase VMA, will not show a high HVA. And some medications, as well as a pheochromocytoma, can increase VMA. These patients are also at risk for myocardial injury and dysfunction. If they have elevated cardiac troponin 1, always look at history and family history, genetics, etc. But keep that in mind that this is putting the patient potentially at risk from a cardiac perspective. Next slide. When HVA is low and VMA is low, it could be that we're missing some cofactors: BH4, iron, SAMe, magnesium, copper, B2, and NAD. We can have a COMT or MAO genetic mutation. Having low HVA, low VMA tells us that those neurotransmitters are low and can produce symptoms of fatigue, addiction, depression, lack of pleasure, boredom, and exercise intolerance. There are lots of other things. Those are just a few. Tyrosine converts into dopamine using those precursors, and then dopamine again converts to VMA using vitamin C, copper. Iron also plays a role in that pathway. We also want to look at estrogen dials again to see if there's too much estrogen, because that will slow down the COMT and MAO. And again, look at insulin to make sure that it is healthy and within range, as well as looking at the adrenals. Long term, THC use is possibly suppressive. There's some mixed research on that, but I think that field is really growing. The field of research in THC short term and long term use and its effect on multiple other pathways in the body. And the other thing is that glyphosate can block the pathway that is not in humans but in plants. That is responsible for the biosynthesis of folates and aromatic amino acids, which causes a problem in the absorption of nutrients in general in humans. That is not a pathway found in humans, but in the plants we consume. Next slide. We're going to look at kynurenate and quinolate. Next slide. And this is the tryptophan metabolism pathway. So we're looking at the very beginning is the tryptophan all the way down to quinolinic acid, which ends in NAD plus. And you can see the kynurenic acid is over to the side. So tryptophan, which is an important amino acid, goes through this metabolism in all of these different pathways, and it's processed primarily here throughout this pathway. This pathway accounts for about 95% of tryptophan metabolism. Smaller pathways are converted into melatonin, serotonin, and melatonin, but most goes through this pathway. And the gut brain axis is a communication, as we know, that goes back and forth between the gut and the central nervous system. And tryptophan contributes to the normal growth and health in both humans and animals, and exerts modulatory functions at multiple levels of the GBA. Tryptophan is the only precursor of serotonin, which is a key monoamine neurotransmitter, participating in the modulation of central neurotransmission and enteric physiological function. In addition, tryptophan can be converted to kynurenic acid, which is actually the anti-inflammatory pathway. So when we look at the gut microbial influence on tryptophan, we're starting to see some research emerge in modulating and changing tryptophan in the gut and the metabolism of that tryptophan by the gut in brain health and cognitive function in general. We're just starting to see studies on that emerge. Next slide. We're going to look at kynurenate. Next slide. And the neuroprotective effects of kynurenate. Kynurenate can elevate if there's a B6 deficiency, if somebody's experiencing chronic stress. If there are higher levels of oxidative stress, because kynurenate is an ROS reactive oxygen species scavenger or oxidative species scavenger. If there's inflammation, possibly from LPS gram-negative bacteria in the gut. So think about leaky gut here. And can also elevate when patients are on a ketogenic diet. Elevated levels have been found in schizophrenia, Alzheimer's, cluster headaches, chronic migraines, and psychosis. And that's because of lower NMDA and acetylcholine. And kynurenate, when it is helpful from an anti inflammatory perspective, can be not such a great thing when it's too high for too long. So, within reason, right? Finding that middle range with kynurenate is really important. Next slide. Kynurenate is neuroprotective. It is an anticonvulsant and is anti inflammatory. It decreases the Th17 response, increases IL-10, and decreases TNF alpha, and protects the blood vessels from high homocysteine levels. All of those things are anti inflammatory in nature. Next slide. Some sources of kynurenic acid. These are some foods that can increase kynurenic acid. Broccoli, potatoes, honey, tea and coffee, alcohol, and then some herbs that it can increase kynurenic acid. Exercise, specifically endurance exercise, increases kynurenic acid production. And kynurenic acid also increases with tryptophan supplements and the presence of chronic infections and inflammation. Next slide. Low levels of kynurenate in the urine can be indicators of depression, bipolar disorder, ADHD, psychosis, and Alzheimer's disease. So when we're looking at the difference on page 6 in the Dutch test of xanthurenate and kynurenate, remember, we're not always talking about B6. It can be an indicator of other things happening related to all things brain. Also, more serious things like a kynurenase deficiency disrupts the normal metabolism of kynurenate and can show lower in urine. Next slide. Some of the biological impacts are for kynurenic acid. The FKBP5 is one of my favorite genetic markers. This is the genetic marker that will tell if the patient, for the most part, is one of those people that when they're exposed to a stressor or exposed to cortisol, tend to internalize that and hold on to stressors. This is the way the person feels like they're wired. So this is the patient that when you tell them, whoa, your cortisol is really out of range and we need to do something to help you manage stress, could you consider maybe a yoga class? And this is that patient who's going to say, oh, do you mean hot yoga? um, with inversion poses like aggressive yoga. No, we mean like yin yoga, things that are going to help you relax. And that patient says, well, I'm at CrossFit 5 days a week, or I'm training for a marathon. So too bad, so sad, I can't do that, right? Those are the patients who are going to need it most. And I am guilty. You can see on mine, I have a pretty big homozygous mutation on the FKBP5. So when you tell me to slow down, it's a lot harder for my brain to accept it, right? I have to do what I say, um, and actually do it, and really appreciate that this is the way that I'm wired. This is my genetic predisposition. So quinolinate is specifically, rather kynurenate, is known as a natural antagonist at the glutamate receptors, particularly the NMDA receptor subtype. This helps protect neurons from glutamate-induced excitotoxicity. It can actually change synaptic transmission. So beyond anti-inflammatory things, it can change the acetylcholine receptor, or really transmission through its effects on the alpha 7 nicotinic acetylcholine receptor. Too much kynurenate can decrease glutamate. Remember that even though we think of glutamate as something we want good balance, right? The right amount of glutamate. We don't want too little. We definitely don't want too much. And there's an influence on cognitive disorders where elevated levels of kynurenate have been associated with several psychiatric conditions like Alzheimer's, schizophrenia, Huntington's disease. And their modulatory effects on glutamate and acetylcholine can contribute to those dysfunctions. Again, we could use this potentially therapeutically in order to monitor treatments, especially for things like neurological disorders, for post TBI treatment. How well are we doing with those therapies? How well are we doing in supporting that patient? Next slide is quinolinate. And this is again that physiological pathway for quinolinate, quinolinic acid. Um, and we could see all the way through that pathway what happens. Quinolinate is one of our newer markers on page 6 of the Dutch test. And when receptors are overwhelmed with quinolinate, it is very inflammatory and creates an excitotoxic or neurotoxic effect, which results ultimately in cell death and apoptosis of the cell, which is never anything that we want. We want to let the cells regenerate at their own rate. It impairs the reuptake of glutamate into the synapse, which means it keeps glutamate in sort of circulation longer. And this process actually snowballs and furthers the excitotoxic effect of quinolinate. So when we start to see that quinolinate climbing on page 6, it is something really to pay attention to and start to really look at the patient from a neurological perspective. What is happening that is elevating that quinolinate? Let's find the reason and start to address it, really quickly. Quinolinate is a really important marker associated with things like Parkinson's, things like Huntington's, things like Alzheimer's, and also ALS. It's also been associated with depression, mood disorders, and risk of suicide in the literature. It can increase because of inflammation. It can increase because of microbial infections. Central nervous system degeneration will cause quinolinate to go up. Taking too much tryptophan and exposure to things like phthalates and lead can cause quinolinate to elevate. Next slide. Quinolinate is an NMDA receptor agonist. It is a biomarker for potential inflammation in the brain. It influences astrocyte function, which not only affects the neurons, but has a significant impact on the astrocytes, which is the most abundant type of glial cell in the brain. It induces astrocyte dysfunction and contributes to the breakdown of the blood-brain barrier, which is directly related to the gut barrier and leaky gut in general. So, blood brain barrier and gut brain barrier. And there's dysfunction in one, there's almost always a dysfunction in the other. So, starting to make that connection. There's also a role in depression and mood disorders. Some newer studies showed that quinolinate can be related to mood and mood disorders in general, probably related to glutamate neurotransmission and its inflammatory effects on the body. And some of the enzyme pathways that quinolinate uses are potential targets for therapy in lowering quinolinate levels. Next slide. Quinolinate has been shown to impact neurogenesis, particularly in the hippocampus, which is a brain area that's vital for learning and memory. There is also a role in mitochondrial dysfunction, which makes more oxidative stress within the neurons and can impair how the body cleans up those levels of oxidative stress. It changes neurotransmitter systems beyond glutamate in the way that it can change both serotonin and GABA, those more calming neurotransmitters, and there are implications in autoimmune neurological disorders. So, some of the newer research has linked elevated quinolinate levels with autoimmune neurological conditions like MS and can contribute to the progression of those conditions. Next slide. Some foods that will dampen some of the effects of quinolinic acid are listed here: garlic, chili pepper, turmeric, black pepper, EGCG, broccoli sprouts, high in sulforaphane, caffeine, grapefruit, pomegranate juice, and saffron. You'll recognize some of those in the list for things that will help modulate levels of estrogen in phase one, especially phase one detoxification on the Dutch test. Next slide. Some supportive treatments to help lower quinolinate are B6, which reduces kynurenate, therefore less quinolinate, magnesium, selenium, L-carnitine, and antioxidants in general. Some other lifestyle supports include balancing estrogen, looking at the adrenals to create good sleep wake cycles, making sure someone's getting enough sleep. Balancing blood sugar and movement or motion in general can help to lower quinolinate. Next slide. MMA, we're going to touch on. Next slide. Um, if there's a deficiency of B12, specifically adenosyl or hydroxy B12, we'll likely see an elevation high end of range or above range on the Dutch test. This is usually from not eating enough B12, absorbing enough B12, or getting B12 into the cells. Remember that it can be blocked by medications like metformin, oral contraceptives. Make sure you're looking at genetics, all of the genetics if possible. I mean, there's lots of other things I get asked all the time. If there's a COMT issue on page 3 of the Dutch test and somebody's MMA is normal, I get the question a lot. Well, if they don't have MTHFR, if they have MTHFR, does that impact this or that? And how important is it in general? And there are so many other genes that play a role in B12 and B vitamins that you can't really just say MTHFR alone. So if we're lucky and we get genetics on a patient, we can really create a super robust protocol for them. We can increase B12 by increasing foods that are high in B12 and by directly addressing the gut. If there's not enough hydrochloric acid, the patient won't be able to absorb B12. Next slide. B12 is an early indicator of neurological compromise. We could see with a B12 deficiency significant neurological complications like cognitive decline, memory loss, and impaired nerve function. There's a clear link to neuropsychiatric disorders. High levels of MMA can be associated with a greater risk of those disorders, like depression and bipolar. Mechanism of that is not really fully understood. There's an association with dementia and cognitive impairment. And there's an effect on myelin integrity. B12 is crucial critical for myelin sheath formation, which is a covering around the nerve. And there's a role in child development around brain health and function. Early detection and treatment of high MMA levels in children can prevent potential development delays and cognitive impairment in kids. Next slide is xanthurenate, the one that we often pair with kynurenate at the top of page 6. Next slide. We can see that xanthurenate, when elevated, is a known marker for B6 deficiency, which is really important for synthesizing neurotransmitters in general, serotonin, dopamine, GABA, really important for mood regulation, cognitive function, and stress response. High levels tell us that there is a deficiency. When we see B6 being involved in general in neuroprotective pathways, kynurenate can be a potential neuroprotective agent, meaning that it acts as an antagonist at the glutamate receptor, which can be very, very helpful. There's a link to the kynurenate pathway. Which again metabolizes tryptophan primarily in the liver, but also in the brain, closely linked to the immune response and is activated during the inflammatory process and is linked to multiple neurodegenerative diseases. It's a potential biomarker for schizophrenia. How well is that therapy working? And it also can have implications for the brain's oxidative stress response. So tying this in with 8-OHDG, pyroglutamate, high 4-OH on page 3, tying it all in together and looking for that thread throughout the Dutch test of inflammation or oxidative stress that we can help find the link and really get in and start to fix these things from the root of where the problem is. Next slide. There is an influence on tryptophan availability because xanthurenate is a metabolite in the kynurenate pathway. Its production can reduce the availability of tryptophan for other pathways like serotonin synthesis, which can lead to lower mood. There are interactions with B6 in the form of P5P, which is the active form. There's a potential role in pain perception. There are some newer research showing that components of the kynurenate pathway, including xanthurenate, may be involved in modulating the perception of pain by the patient, and their implications in metabolic syndrome. While although not directly related to brain health, metabolism in general can indirectly influence brain function through systemic health. Think fuel for delivery for the brain, like blood sugar and oxygen coming from iron. Those influence brain function through systemic health. Next slide, pyroglutamate. Next slide, pyroglutamate. When elevated, shows that there's a glutathione deficiency. Glutathione is our most potent antioxidant. We could see here in patients with a GSTM1 homozygous mutation, often that gene is missing, which means often a lifetime of glutathione supplementation aggressively in food and or supplementations. When pyroglutamate is high, glutathione is not being made, recycled, or is being used up really quickly by lots of oxidative stress in the body. We always want to look at other cofactors. We also want to look at as many genetics as we can related to those things, making sure too that the diet has enough amino acids. Next slide. Some conditions that are linked to high pyroglutamate in the literature are listed on the left: Alzheimer's, Parkinson's, Huntington's, ALS, migraines, MS, autism, ADD, ADHD, bipolar disorder, and depression. Pyroglutamate is formed from glutathione breakdown. And again, it's the body's most potent antioxidant. And when there's a lot of oxidative stress, the glutathione can be used up. There's a potential link to cognitive disorders. It plays a big role in brain metabolism and neuroprotection. In general, it's not only helpful for levels of oxidative stress, but it's also neuroprotective from other aspects of brain health and also involved with rare genetic disorders when elevated. Next slide. Indican. Next slide. And what we found was in mice, in a study that I found in mice, not in humans, but in mice that were raised in sterile environments, which we refer to as germ free mice, there was a much more exaggerated physiological reaction to stress compared with normal controls, which were reversible through probiotic induced bacterial recolonization, which I find really amazing. Is that working on the gut with specific bacteria, as we're starting to see more and more of these things emerge? We're calling them psychobiotics, working on the gut and leaky gut and putting good bacteria back into the system, healing the potentially leaky gut and healing the gut barrier also can indirectly and then directly really help heal the blood brain barrier. And using things directly in the gut that can make those changes is a really powerful way to help change brain health and neurological function in general. And I think the research is really growing and changing there. Next slide. We have 8-OHDG. Next slide. 8-OHDG is a marker of oxidative DNA damage. So when that's elevated with neurodegenerative conditions, when oxidative stress is a known factor, we start to really hopefully pay attention on page 6 of the Dutch test and say, okay, we really need to pay attention to this and make some changes. Where is this oxidative stress coming from and how do we lower it? We have found a link to cognitive aging. High levels of 8-OHDG in the brain and CSF have in particular been associated with the aging process, particularly in the context of cognitive decline. We're seeing that it is also a predictive marker in neurodegenerative diseases. So, in somebody with a known neurodegenerative condition, higher 8-OHDG levels can mean things moving in the very wrong direction. 8-OHDG plays a role in mitochondrial dysfunction as well. It's not only a marker of nuclear DNA damage, but also mitochondrial DNA damage. That's really huge and super important in terms of cellular function in general. It also has an impact on neuroinflammation. So, not only direct DNA damage, but it's involved in activating inflammatory pathways in the brain. Also, a terrible thing to have happening in the brain. And it also has an association with psychiatric disorders. So, 8-OHDG can be linked to things like depression and schizophrenia. Next slide. 8-OHDG also has an impact on gene expression. Damage to DNA is direct and can also actually alter gene expression patterns in the brain. It has an influence on neurotransmitter synthesis, which changes the body's ability to be able to synthesize and degrade really important neurotransmitters like dopamine and serotonin. Could hardly be more important, right? There's a correlation with blood brain barrier integrity. Oxidative stress with a higher 8-OHDG can compromise the integrity of the blood brain barrier. And that compromise in the blood brain barrier lets neurotoxins and pro inflammatory cytokines, as we know, enter the brain more easily, damaging neurons and making cognitive dysfunction even worse and accelerated. There's also a really valid role of 8-OHDG in the sleep wake regulation. So we're starting to see emerging evidence. When we think about it, it makes a lot of sense that sleep is when our brains clean up, right? And we get rid of all of the junk that's in there. It's our body's time to heal. And poor sleep quality and altered circadian rhythms, really important, are known to affect cognitive functions, mood, and overall brain health. A brand new study just came out, I believe, in the month of June, showing that even in people who have a chronotype that shows that they are a night owl, for example, tightening up that time frame and getting to bed by 1 o'clock in the morning and not letting it go to 3 o'clock in the morning makes a huge, huge difference in brain health. So even people who say, well, I'm a night owl and I just go to bed at 3 o'clock in the morning. Well, we're now just starting to see that if you can tighten that up and be in bed by 1, it does make a huge difference in brain health. Next slide. Making the connection between organic acids, hormones, and brain health. Next slide. Interaction with hormones. Estrogen and cortisol interact with neurotransmitter metabolism mediated by organic acids. This is one of my favorite parts where we get to talk about the connection between everything, where there is like a magic thread weaving through the Dutch test, and we can find that thread and see why things are happening, right? We want to find it and we want to follow it all the way to the very bottom where we find that root. So when someone has high estrogen, we don't just want to say, okay, their levels of estrogen are high. Let's just use DIM. We want to know, why is it happening? Is their detoxification pathway affected? Phase 1. Is phase 2 not working the way it should? Is phase 3 through the cell, out of the cell, and then into the gut? Is that modified and altered? And what do we need to do to find the root of the problem to fix why is the estrogen high in the first place? Is it early stages of perimenopause where progesterone is lowering? We then have a relative estrogen dominance, and then estrogen levels start to climb before they finally start to drop, which is then going to change levels of serotonin in general. And then cortisol, when we look at those things in general, hormones like cortisol and estrogen change synaptic plasticity and influence overall brain energy and metabolism. So they're so important when we're looking at everything together. We want to look at page 3 while we're looking at page 6, really page 1, 2, 3, and 4, really 5, the whole Dutch test, when we're looking at how these things are working together as far as the way someone learns, their memory, executive function in general. Next slide. By estrogen significantly affects the synthesis and metabolism of not only serotonin, but also dopamine. Changing estrogen levels, which you get to see really well in a cycle map, affect mood, it affects memory, it affects cognitive function, especially notable in perimenopause and menopause, some of the hardest things I've ever tried to treat in practice because they're so changeable and variable in different person to person. That's really where you can take it to the next level by adding genetics to this, to the view of the patient and looking at it through that lens. Estrogen is known to enhance synaptic plasticity by increasing the density of dendritic spines and modulating neurotransmitter receptors, including NMDA and serotonin receptors. Estrogen is responsible for that, which I think is really amazing. And lowering estrogen during perimenopause and especially menopause leads to lower synaptic plasticity, less memory efficiency, right? Harder to find words, harder to process things. Estrogen is so important, really, really important when we're talking about cognitive health in women as we're aging. Next slide. Cortisol, which is usually called the stress hormone, influences lots of different neurotransmitters, serotonin and dopamine, as well as emotional regulation and cognitive function. Chronically elevated cortisol can lead to cognitive impairment, increase the risk of developing psychiatric disorders like depression and anxiety. Cortisol facilitates memory formation and retrieval by interacting with glucocorticoid receptors in the hippocampus. Chronically high cortisol can lead to hippocampal atrophy, literally the hippocampus shrinking, reducing synaptic connectivity and impairing cognitive function. And high levels in cortisol due to chronic stress or adrenal dysfunction is associated directly with cognitive decline. Next slide. Estrogen, cortisol, and neurotransmitter metabolism. We want to watch for fluctuation in estrogen. We want to watch cortisol levels, and we want to make sure that these things are as even as possible. Kind of like Goldilocks. We don't want too much. We don't want too little. Right down the middle is the ideal. It's really important in how the body responds to stress, both from an estrogen and cortisol perspective. Estrogen modulates neurotransmitter levels directly, And cortisol can reduce serotonin synthesis and increase the catabolism of norepinephrine, leading to mood destabilization and impaired cognitive function, which I believe a whole other talk in general, but can really, I think, highlight the benefit of hormone replacement therapy. I'm looking at, is this patient a candidate? Let's look at their estrogen levels in general. Next slide. And this is where we see in this patient that we saw in the beginning low levels of estrogen compared to progesterone. Looking at the hormones when we look at neurotransmitters, or most importantly, really paying attention to page 6 and not skipping over that page, looking at the connections. Where can we find the connection between everything in general? Next slide. Remembering that cortisol awakening response and how important it is in general. Next slide, addressing that low cortisol awakening response, starting with the brain, doing all the things we need to know, making sure the gut is healthy, vagus nerve is appropriately stimulated. Next slide. With a high cortisol awakening response, making sure that the patient has some calming support, that they're able to sleep, that they're not waking up with anxiety, stimulating the vagus nerve, making sure the patient can get from sympathetic over to parasympathetic, really important. And fixing sleep can help with roughly half of cortisol awakening response issues in general. Next slide. So, personalized medicine and cognitive health. We want to pay attention to the patient. We want to listen to their symptoms, and always look at that. Look at the patient and their test results through that lens. So, when I'm talking to you, provider to provider, I want your help in understanding the patient. I want to know what the patient told me, but I also want to know what your perception is. What are you seeing in that patient, so that together we can help create the most robust protocol for your patient in general. We guide you by helping you interpret the test results to create a protocol that's really going to optimize patient health by incorporating hormone levels as well as organic acids, paying attention to everything in general. We want to pinpoint the underlying issue, oxidative stress, cortisol dysregulation, and look at multiple different systems to create the best approach and the most effective treatment for the patient. Next slide. Some key takeaways. We saw the central role of organic acids in assessing brain function by looking at those metabolites that reflect neurotransmitter activity, looking at the interaction between hormones and brain function, and seeing just how important all of those things are together, looking at nutrient deficiencies to see, well, why are these things happening? Why are they not absorbing the nutrition? Are they not taking in enough? Can they not break it down in the gut? Can they not absorb it in the gut? Looking for the root. And integrating metabolomics and hormone analysis to really create a robust protocol, again, for the patient. So we looked at cognitive health, brain function, and how they look at not only neurotransmitter levels, but also really look at the bigger impact of things like estrogen and cortisol, as well as neurotransmitters on the brain, and cognitive function and brain health, to create effective interventions and really enhancing overall patient outcomes. Next slide. Thank you so much for your time today. If you have any further questions, please do not hesitate to book a consultation with our team. We love to get to know you. We are here because we are obsessed with the Dutch test, and we love you and want to talk to you, and we are here because of you. We want to get to know you and help you interpret these tests. The Dutch test is amazing because there's tons of information, but that also can make it a little bit overwhelming. So do not hesitate to contact us. We have great courses available to mastering functional hormones and hormone replacement therapy, a beautiful interpretive guide that you can use now in your portal to be able to interpret your test results. But please don't hesitate to call us. We have several ways to reach us. Please reach out if you need our help. I really, really look forward to our continued collaboration together to really enhance patient care through looking at the Dutch test and the results on the Dutch test, and helping you create really personalized treatment approaches for your patient. So thank you so much for being here today, and thank you for your time.
Thank you all for joining us today. Watch your inboxes tomorrow for a link to the recordings and to access the resources we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research, and make sure to visit the Become a Provider tab at dutchtest.com to register for an account so you can gain access to even more hormone education and research. And don't forget to follow us on Instagram at Dutch Test for more hormone education, tips from our clinical experts, and more.